at our meeting, and I'm very excited to introduce Dr. Jen Thomas. So Dr. Thomas is a pediatrician and breastfeeding medicine specialist in Franklin, Wisconsin, and is a clinical assistant professor of community and family medicine of pediatrics at the Medical College of Wisconsin. She received her MD from the Medical College of Wisconsin, as well as her MPH. And she has been an international board certified lactation consultant since 2003 and is currently serving on the AAP's section on breastfeeding executive board after spending several years as the chief of the chapter breastfeeding coordinators. She is the author of Dr. Jen's Guide to Breastfeeding and has received national awards for teaching, advocacy for children, and innovation within her practice and community. Today, we are very fortunate to have her speaking on two different topics. The first will be tongue tie. What is the evidence? Please help me welcome Dr. Thomas.
Hello. Hello, everyone. I am so sad that I am not there with you today. I am in lovely Wisconsin. And after I saw like the music selection and the dancing, I am really sad that I am not in Vegas right now. You guys look like you know how to throw a great party, but I'm still very happy to be with you in my house in Wisconsin. I am a pediatrician. I am Dr. Jen for Kids pretty much everywhere on social media. I need to tell you that I don't plan on saying anything that doesn't have some data behind it. I do want to share that I breastfed all three of my sons with varying degrees of success. And as we talk a little bit about inherent bias and what's happened in breastfeeding, I think it's important that we all sort of share potential biases. So I didn't do well with one of my kids and I did pretty well with the other two. So big hot topic right now, which is tongue tie. It came out of nowhere. It went really fast. And we are now working on a clinical report for the AAP. I'm one of the authors on the clinical report that is being fast-tracked and considered very controversial. So we've been working on it really for a long time, and we're very excited to see that we potentially will have the chance to get that out to you guys very soon. So just in case you don't know where Wisconsin is, I'm in Milwaukee. We are the epicenter of COVID right now. This is what it looks like. This is our art museum. It has wings that open and close during the course of the day. It's actually the same architect who worked on the Sydney Opera House. We are very famous in Wisconsin for wearing cheese on our heads. We are America's Dairyland, as our license plates would tell you. And somewhere along the line, we took milk from a cow and called that milk. And then we started talking about breast milk being the stuff that we feed to little cheeseheads. So what does the American Academy of Pediatrics say about breastfeeding? This is from the 2012 policy statement. Our new policy statement is written. We are waiting for it to go through channels. So we will have an update to this. We're not going to see much of a change. Well, to this statement, we might actually. The American Academy of Pediatrics reaffirms its recommendation of exclusive breastfeeding for about 6 months, followed by continued breastfeeding as complementary foods are introduced, with continuation of breastfeeding for a year or longer as mutually desired for mom and baby. We also, in that breastfeeding and the use of human milk policy, we address also what the role of pediatricians is. And pediatricians play a really critical role in their practices and communities as advocates of breastfeeding. And we should all be knowledgeable about the health risks of not breastfeeding, the economic benefits to society for breastfeeding, and then learning how to manage and support the breastfeeding diet. So when I have given this talk in different parts of the world and different parts of the country, people are always like, do I need to be you? And I'm like, God, no, please don't be me. Do you need to be an expert? No. But having an opinion and supporting your opinion with science, and we've seen this more and more frequently, that matters to the patients for whom you care. So I'm going to help you do some basic problem solving, and then I'd like to share some of the ideas of where to get qualified help. So I did a search on how you guys did for breastfeeding in Nevada, and it's really quite impressive. So your ever breastfeeding rate has been around 80% since 2009. And if you think about this, there are like very few topics where 80% of our parents want something with that we don't routinely give. So I'm hoping to motivate you today to take a more active role in helping your patients breastfeed. So it looks like, so our 2020 goals, and it's obviously 2020, so we were supposed to have met them. Our 2020 goals were 75% initiation. You guys got there. It's been 80% since 2009. And then we want 50% of those moms who started breastfeeding to continue till 6 months. And you guys got there essentially in 2013. And then what we are looking for, and it's a new metric this time from the CDC, is exclusive breastfeeding at 6 months. And that goal for 2030 now is exclusively breastfeeding at 6 months. We want 42% of the women who start breastfeeding to continue breastfeeding exclusively for 6 months. And that's not just going to take us, it is going to take legislation, it's going to take advocacy, it's going to take workplace legislation, it's going to, so many different things need to happen in order for us to meet that goal. But the exclusive breastfeeding rate in Nevada looks like it's been at 25%, somewhere around there, and we're trying to get to 42%. So we've got a lot of work to do for exclusive breastfeeding. So before I can talk to you about tongue tie, I'd like to show you what a normal latch looks like, because a lot of understanding pathology of the latch means that you understand what the latch looks like. So I'm going to share a little bit of that information. So in order to determine how a lingual frenulum might impact on a baby's breastfeeding, we have to understand, what does the tongue actually need to do during breastfeeding? Are there other parts of the baby's anatomy that might interfere with the ability to latch? And then find out if the presenting problem could be explained by something else besides restricted tongue movement, because that's going to be our role as pediatricians to make sure that that baby's poor growth or poor feeding isn't due to some other medical problem. This is a video I snagged from a colleague. She's an otorhinolaryngologist in New Zealand, and they're not ENTs, they're ORLs there. And she managed to convince moms and babies to get into MRI machines and get videoed. And I just think this is just beautiful to watch. We're going to see lots of variations on this, but you can see here that the tongue takes up nearly the entire oral cavity. You can watch the journey of the milk into the stomach. We just watch this really beautiful interaction between mom and baby. We're also going to talk about how the neck is slightly extended and where the baby needs to touch the breast in order for them to have a good latch. So we always talk about babies being obligate nose breathers, and one of the reasons that they are obligate nose breathers is because their tongue takes up most of their oral cavity. What's going to be able to happen with this larger tongue is that the elevation will push the nipple to the hard palate, and that is going to be able to create a vacuum, which will then result in milk removal. So the large tongue of the infant is really designed to help them breastfeed. So we're also going to be taking, this is the tongue, this is the nipple. The nipple usually extends to the junction of the hard and soft palate, which we aren't going to be able to see unless we have Dr. Mill's great imaging techniques. We're also going to be talking about what the lip is supposed to be doing. And you're going to see in most of these pictures, the lip doesn't need to do anything except exist. This work is from the University of Western Australia. Donna Geddes does a ton of work. It's like the land of whatever breastfeeding research project you can come up with. And what they were using was ultrasound to take a look at how much the tongue needs to move and by what mechanism the tongue is creating milk removal. So in this ultrasound, we're going to see the junction of the hard and soft palate. This is the nipple right here. And you can see that the tongue takes up most of the oral cavity. What they found by ultrasound study is that the tongue moves down, which creates the vacuum, and then the milk is sent as a bolus to the posterior pharynx. And so the movement of the tongue is creating the vacuum and is also creating the mechanism by which the baby is going to handle the milk bolus. So I'm going to show you, this is the anterior tongue, what the baby does with the front part of their tongue when they're breastfeeding. I need that baby to get moving there. All right, so we see that the anterior is moving an awful lot. And it turns out that by ultrasound studies that Donna Geddes and Nikki Mills have done is to show us that the anterior tongue needs to be able to move probably 6 or 7 millimeters up to create an elevation so that they can compress the nipple on the hard palate. And the posterior tongue, and we're going to hear a lot about posterior tongue ties if you haven't already, but the posterior tongue isn't doing much. It's helping the bolus of milk get into the posterior pharynx, but the back part of the tongue doesn't do nearly as much motion as the anterior tongue does. So again, we're going to see the nipple elongates. It is really incredibly elastic. It moves to the junction of the hard and soft palate. The lip is not everted. It is not phalanged. And what you're going to see a little bit now too is how great that slightly extended neck posture is going to be for the baby to be able to breathe and suck and swallow and coordinate that. So the positioning at the breast is going to be really important for the baby to be able to breathe and eat. This mom's got an implant, which shows you that you can breastfeed with an implant in an MRI machine. So again, we're going to start talking about the nasal pharynx. And if the baby's neck is slightly extended, that traveling distance from the anterior nares all the way down to the lung, it's pretty much a straight shot. So if the baby is in the correct position, then the baby is going to be able to move their tongue to create the vacuum that needs to happen. And they are going to be able to breathe because their nose is perfectly in alignment. So that obligate nasal breathing allows babies to maintain a latch while they're breastfeeding. So I want what it looks like, and I'm not going to show you I'm not going to show you sort of the traditional ways to do this, because there are all sorts of different ways that people have taught latches over the years, and there's very little evidence except for this one. So this is a baby-led attachment. This baby is awfully cute. And the baby, and you can do this with your own patients. You just sort of let the baby make the journey.
Instinctively move breast. She will start to lift her head round. As she moves towards a breast, you may find it helpful to hug her bottom in close to you.
So there's a lot of explanations on there that are not very helpful, because that is just oral tradition, which is hard for me to talk about when we are doing this, when we are talking about the evidence, right? There's really no evidence that we have right now for most of the holds that moms and babies do. This is from a study that was published 2 days ago, and it really shows that even in babies, this was done specifically in babies with laryngomalacia. And for the traditional holds that moms usually keep babies in, like a cross-cradle position, the baby has a really hard time with the suck, swallow, breathe mechanism. And Dr. Mills has given me really cool endoscopy videos of what happens when the babies are in a dependent position underneath the breast. So that is that is problematic because the correct latch really needs that the baby, and it's going to be D right here. The baby needs to be upright. Their feet should be anchored on something. Their neck is slightly extended. They have a bunch of body support. For kids with unstable airways, even kids with just laryngomalacia, the tongue comes forward. And because they're not in a gravity dependent position, the baby is able to control the rate of flow. So a lot of the things that are associated with tongue tie have to do with clicking noises and reflux and things that are probably related to positioning. So if we can help doing an evidence-based positioning, which is this one right here, that the babies can get to by themselves, it's so cool. So what I will do is put the baby on dad's chest, and the baby has this motion that on that video that you just saw, the baby will climb down towards the breast and we'll do a latch where they can self-attach. I learned so much by watching babies self-attach to the breast. The kids are going to pick a latch that allows them to remove milk at a rate that they can handle. And a lot of the times when I am asked to do a consult for somebody because of tongue tie, I usually do everything I can to arrange to see the baby nurse before I ever address the tongue. So what we know from evidence is that babies can self-attach. When they do, they're semi-prone, mom's comfortable, so she's not leaning over the baby. Baby's neck is slightly extended and their feet are anchored. So this is it. It is the laid back latch. This is the one that we know the most about. It says here that most full-term babies are born knowing how to latch in this position. There's an abundance of research looking at the effect of things like epidurals on the baby's ability to do this self-attachment latch. And if you think of other mammals scoot along, they find the nipple by themselves, they're on their bellies, and they know how to suck, and there is no lactation consultant that pops out to help them. And so there's really this wonderful instinctive and empowering lesson that you can teach for the moms that the baby can get there to themselves. And here, my favorite part of this is that mom gets to be comfortable first, because there's so much breastfeeding that happens in those initial weeks that sitting and laying over your baby can really start to hurt your back. You also see that some of these positions now don't go with what we know babies know how to do. The cross cradle position, the side lying position, the cradle position, all really require mom to hold onto her breast and sort of smush the baby's head on, which I still see all the time, which we really shouldn't be doing, especially when we know that babies can attach by themselves. And then this one, and I'm looking at you, football hold. A, none of us played football. B, in some parts of the country, the football is round. And C, this mom is not going to be comfortable. They always talk about how this is important for cesareans, but they make the mom sit up and bend over the baby. The baby is supine, which works against their feeding reflexes. And nearly every baby, when they latched, has their head in flexion, which makes it so much more difficult for the baby to remove milk while still mastering suck, swallow, and breathe. I have tried for many, many moons to educate lactation consultants to say, man, we got to stop doing this. There's no evidence for this. But there is a very strong history of, I did this and it worked. And so that has been a much more of a challenge to deal with. All right, so tongue tie. So in case you hadn't noticed, there's a lot of people who are worried about tongue tie right now. Canada has seen an 89% increase from 2004 to 2013. In Australia, between 2006 and 2016, there was a 420% increase in the rate of frenotomies per 1,000 children. And similarly, in the United States, there's been an 834% increase between 1997 and 2012. And at least one study done in 2012 said that if you are a Midwestern white boy, you are at much higher risk of getting your frenotomy taken care of. So what's the biggest challenge? I just showed you 80% of the people in your state are starting to breastfeed, and not many of them are making it to exclusively breastfeed for 6 months. And we have gone through phases in lactation where we were blaming yeast and we were blaming, a bunch of stuff. So now it's come to, well, it isn't yeast and it's probably not staph and it's not this and it's not this. So what is it? Why am I in pain? And how can you help? And it is a very, very enticing thing for a breastfeeding mom who is having problems breastfeeding to think that a single couple of snips is going to fix her breastfeeding problem. Our moms are looking for our help, and we need to be able to help them. And at least one of the reasons I think that pediatricians are a little bit sort of caught in the middle of this is that we sort of poo-pooed it at the beginning, saying, I don't know that this is actually real. And so clearly, this is overdiagnosed, absolutely overdiagnosed. Many more moms are breastfeeding, they're having problems with it. We don't know if this is an increasing diagnosis or if this is an increasing awareness. And this is just fraught with problems because every scoring system to find out what tongue tie looks like is based on photographic evidence of the baby. And this is really a functional diagnosis. And this is a functional diagnosis between mom and the baby. So any scoring system that doesn't look at the latch and doesn't consider maternal pain or like I have a mom who's her 8th baby was tongue tied. Her nipple could stretch about that long and she didn't have any problems. So the baby wasn't tongue tied then, the baby has a lingual frenulum. So tongue tie is a functional diagnosis. We don't have any very good real criteria to diagnose tongue tie. It is what took our AAP policy statement on tongue tie and knocked it down to a clinical report because there's just not a whole lot of evidence about how we are supposed to proceed. One of the things that we're seeing in the clinical report on tongue tie, our little task force, is that lactation consultants don't see pediatricians as a resource for breastfeeding problems. And what they're doing is referring to dentists. And the dentists are oftentimes ill-equipped to take care of newborns because they don't have a lot of education in newborns. And they aren't billing insurance. And so this now tends to be a disease of the affluent because the charges that they're doing are anywhere from like $75 up to $1,000 a cut. And these people are paying out of pocket because they are desperate to get some help with breastfeeding. So the pediatrician has sort of been just removed from this entire discussion. What also happened was that the online information was out of control and it got way ahead of the research. And really importantly, other causes of poor feeding have been missed. And so we really need to figure out how pediatricians can get back in this loop. So here's an example of photographic evidence looking for different degrees of tongue tie. None of these scoring systems have been validated. So the interrelator reliability is lousy. This is the anterior or traditional tongue tie. These are varying degrees that I don't know have a lot of clinical relevance until you see the baby latch. And this is the infamous posterior tongue tie, where you sort of have to hallucinate that there is some type of restriction. This is an important study that was just released last year. And basically what this is saying is that traditionally tongue tie was, the frenulum was seen as a separate structure. So it was a discrete structure that went along the ventral surface of the tongue and that it was a midline defect, which led to all sorts of things about having an MTHFR lesion. And really it is not a discrete structure. The frenulum comes from the floor of the mouth and it attaches to the ventral surface of the tongue. And so when you lift the tongue, you're lifting the floor of the mouth and everything is coming with it. The whole tongue is coming with it. So it's not a separate structure. It is actually the fascia of the floor of the mouth that is connected to the bottom of the tongue. And the more that you lift the tongue, the more that you see that frenulum, and it's 99% of all people have that frenulum because nearly all of us apparently have a floor of the mouth. So in 2015, the first report looking at the evidence that was being presented for tongue tie, it was just very frustrating. And having to have read this for our clinical report, they were doing, like there were 3 randomized controlled trials where there was a sham procedure done. And then every single person in the study, including the controls, had a frenotomy done. And so it's just very frustrating to read. But in 2015, the ARHQ said that there were improvements in breastfeeding as reported by mothers and potentially in nipple pain. But there were small short-term studies, they were inconsistently conducted. And so their strength of evidence was generally low to insufficient to recommend this procedure. There were really no other outcomes that were addressed by the literature. So we're seeing things online about speech deficits and teeth crowding, and I'll show you a list of what shows up on the internet. So right now, and it really hasn't changed too much from 2015, but it really looks like we should repair anterior tongue tie for maternal pain with breastfeeding. In 2017, the frenotomy reduced breastfeeding mothers' nipple pain in the short term. They didn't find a consistent positive effect on infant breastfeeding. There were no serious complications, but the total number of infants was small, and there were all sorts of methodologic shortcomings. It was a really painful bunch of papers to read. So this is Dr. Bobby Gahary. He's a lot closer to you in Oregon than to me. But this is what happens when you laser a frenulum. You apparently touch that surgical site with ungloved hands. And when you lift up this and make your cut, and in his case, the laser, you are looking for the diamond. And it's an interesting endpoint without any real evidence to it. When this picture was posted, we didn't actually understand the anatomy of the frenulum yet. So it was a little premature to actually work on this and say that a cut this deep, and sometimes it goes into the muscle. There is obviously some concerns about what happens when you do this to a very young baby because of oral aversion. But this is sort of the standard of surgical care, that when you do the frenotomy, you want to see the diamond. And subsequent anatomic studies, it's probably some part of the lingual nerve here, and we don't really have any good evidence that the lingual nerve is not being damaged. So what we know about tongue tie is that there's no good scoring system, but it is a functional diagnosis of the mom and baby dyad, which means we need to learn what a good latch looks like. We know that anterior tongue movement is necessary for breast milk removal. So we absolutely think anterior ties should be treated. We don't have any other indications, including speech or, I don't know, large tonsils or adenoids. They're actually recommending tongue tie release for snoring. It's very hard, you know, and we've seen this in all sorts of different things on the internet, right? Is that your brain doesn't even go to those outcomes. And so it's really hard to predict what is going to happen with the information. But right now we don't have any other indication for the release of tongue tie other than pain with breastfeeding, which is significant because pain with breastfeeding leads to weaning. And that means those babies are not getting breast milk. And so we have to figure out what is actually wrong with the baby if it's not the tongue tie. One of the things that we did in our clinical report is survey members of the section on breastfeeding and the Academy of Breastfeeding Medicine and ask them to share what kind of complications that they have seen. And really the biggest complication of frenotomy is the missed diagnosis. So the kids are undergoing a relatively benign procedure. And in my practice, I've had 2 kids with cardiovascularly significant VSDs whose poor feeding was blamed on a tongue tie, and the kid went through I think first one went through 3 tongue tie revisions, and nobody had notified the pediatrician that the baby was feeding poorly and not gaining weight. And so in our brief survey, and that the biggest misdiagnosis was cleft palate. I also want to address the other kinds of ties, the lip tie, the buccal tie. We talk about lasers, stretches, body works, all the things that we don't have a lot of evidence for. So this is one of the diagnostic criteria for lip tie. This is the most commonly used. It goes from having minimal attachment all the way to a very thick attachment. And typically when you have these kinds of scoring, you'd want the scoring to represent greater severity of problems. This one doesn't. It is just 4 different constructions of what the normal newborn's frenulum may look like. And again, I'm going to continue to show pictures like this. We didn't know what the lip is supposed to do. And so we were probably pathologizing normal when the lip tie came into consideration. So it's hard to create a disease process when you don't actually know what the lip can do. And I personally have been able to help several families whose kids have had a cleft lip be able to breastfeed. And so really the lip is there to create a seal. And we can do that with babies with cleft lips by being a little creative. But the lip doesn't have to have any particular stretchiness or range of motion. It just needs to be in a neutral position. So big problems with lip tie. We don't have any studies on it because nearly every time the lip is manipulated, it is because there's a tongue tie that's going to get corrected. So procedures for lip tie are often done in conjunction with tongue tie, so we don't know what procedure actually helped. Nearly every time that a lip tie has been found, or just a labial frenulum has been found, it's been in the context of a breastfeeding problem. And so there are very few times that we've looked at it to find out, like, what is it supposed to look like in newborns? So the assumption in the public domain is that the presence of any frenulum is abnormal. But it turns out that when we do look at a series of normal kids, most of them have a type 3 or type 4 lip tie. So what is normal tends to be the lip tie anatomy. So I can't call it a lip tie with a straight face. I have to call it a labial frenulum. So what we do know from subsequent studies is that the frenulum changes in appearance. It usually is thick. It attaches prominently on the maxilla, and then it really becomes less prominent with increasing age. It's not clear that the way that the frenulum looks in the newborn is the way it's going to look when the kids get older in life. And then because we don't understand what the lip actually looks like over time, reduces the legitimacy of performing preventive procedures on the frenulum. And the most commonly suggested reason for lip tie is dental decay, because the presence of the frenulum makes it hard to brush the teeth. And I think that can be overcome by simply advising the parents to be aware that sometimes a thicker frenulum makes it harder to brush the teeth. There's actually no data on that. That is just a potential risk. We're also seeing anecdotally that the kids who are getting lip ties done because the families don't want a diastema in between the 2 front teeth, they're getting the ties, the lip tie, the labial frenulum cut, and the scar tissue is actually creating a diastema when the kids are older, so sort of undoing what you wanted it to do. So when you talk about lip tie, people are like, well, my dentist said that it's going to cause a gap in the teeth. And you think to yourself, like, wow, I really don't want my kid to have a gap in the teeth because terrible things could happen. They could be Madonna or Elton John or Michael Strahan and be wildly successful regardless of what their teeth look like. So I want to share this with you because this is just an example of what the literature looks like. And this was a study looking at a way to validate Kotlow's lip tie scoring system. So what they did is they pulled up a bunch of pictures of newborns, and then the investigators looked at it the first time, and then they were given the same set of pictures a second time to find out if they could agree with each other and agree with themselves. So the results showed that all newborns have a labial frenulum, with most attached at the gingival margins, and the raters could not, the inter-rater reliability was 64 to 74% when they were going against themselves, like they couldn't agree with themselves. And the intra-rater was 8%. It just is not a very good scoring tool to say, well, my baby has a type 3 lip tie. And because a type 3 lip tie could be in 5 minutes a type 4 lip tie, and we don't know. So the Cotlow classification of lip tie, which is the one that is most frequently used, it's not reproducible by relevant experts. The majority of infants had a significant level of attachment of the labial frenulum. And as more procedures are done to release the upper lip frenulum, it's important to understand which degree of attachment is normal or common. What the investigators in that last study did was they tried to tweak the Cotlow scoring system to see if they could make it more accurate. And it went from 8% to 38%. So it was really difficult to extrapolate to clinical significance, frenulum function, or to justify procedures to remove the superior labial frenulum. And there's no expert consensus on this. The ear, nose, and throat doctors came up with a consensus policy a couple months ago, and they recommended not to fix lip tie until there's some evidence of pathology. And really what needed to be done first, and it looks like Dr. Mills is working on that, is looking at what the lip is actually supposed to be doing during breastfeeding. And here's the information on buccal ties. There's nothing. I don't know what its biological plausibility would be, but we're certainly seeing problems from this because the kids will go in, they'll get both of their dimples cut, then they will get the tongue tie released and the lip done, and now they won't let anybody come near their face. So they create all sorts of oral aversion. The other thing that happens when the kids go to a laser provider is that they are told to break open the scar and do stretching exercises where you open the wound so that it doesn't reattach. And so depending on the provider, this can happen like a couple of times a day to up to a dozen times a day, where the families are going in and breaking open the scar that was left from the diamond after the laser. So I think it's important to understand where your patients are coming from if they start to ask you about lip and tongue ties, because a lot of them have come on a journey and they are desperate for an answer as to why breastfeeding is not going well. And this is a very tempting answer because with just a couple motions of a laser, they can get their breastfeeding experience on track. So what's happened is that the internet experts have been publishing on Facebook pages, and they've created tongue tie societies, and nothing really has been going through the peer-reviewed process. Many of them are not billing through insurance, so families have to lay out considerable amounts of income in order to pay for the procedures, which creates a huge inequity in the provision of this procedure. The people who use lasers say that they have less bleeding, less chance of infection, and quicker healing, but there are no studies that indicate they are better than scissors. This is not a bloody procedure, so there wasn't going to be less bleeding because there just isn't a lot of blood with this. This is a procedure happening in the human mouth, and if it goes well, then there should be breast milk dousing that area, which is rich in anti-infective properties. And so there wasn't going to be a big chance of infection either. And I don't know how it heals quicker when you're actually burning tissues. We are, with our clinical report, constantly monitoring what's happening on the internet. And we are really seeing this happening a lot more, is that kids just their breastfeeding problem isn't getting any better. So, and that's the biggest tragedy, that if the kids have to go through this tongue tie and lip tie procedure and they're not any better at breastfeeding, then we didn't help this family at all. There is a significant contribution of sunken cost bias where people who have to have paid $1,000, $2,000 for the procedure out of pocket want it to mean something. I've spoken about oral aversion from the procedures being done at once, from the stretching exercises, and the bleeding complications actually happen from the stretching exercises. And it's not clear to me that when laser providers are doing this, that they're asking if the baby had received vitamin K. So this is one of the internet memes. This is actually a very common meme that is on Facebook. And really, when you take a look at this list, it's pretty much everything that normal babies have. So fussiness and gassiness and gagging and reflux. And I love the fact that you can have too much milk and too little milk in the same sentence, because that is not how milk supply works. If your baby is not removing milk, you cannot make more milk. And so I don't know how oversupply can be a sign of tongue tie, but there's a lot of things on here. Car seat discomfort, biting during nursing, premature self-weaning before 2 years of age. And it's just, this one is all Thai babies have high or bubble palates. And I just don't, I can't get my brain to go in this direction. But this is what happens. The moms, they post on Facebook sites. There's a lot of pressure for these moms to get their baby the procedure because of the sunken cost bias that other people have put into this. And there's really a ton of bullying that happens to the moms. And so I have learned over this time frame, and I snip anterior tongue ties. I release those after I've made sure they don't have congenital heart disease or a cleft palate or some other reason that they're not gaining weight. But these families, when they come to you with concerns about tongue tie, there's been a lot of pressure on them online to try to figure out if their kids are tongue tied. So we know that there is a correlation between anterior tongue tie and maternal pain with breastfeeding, and that we should fix that. If we can fix it, it's an easy procedure, not hard to do. We don't recommend stretching exercises. Their babies do not have to be prepared for this. That is one of those things that's online as well, that the babies need to see a therapist to get them ready to suck at the breast. It's a suck reflex. I don't know how we do therapy for that, but we need to be able to help these moms, and we cannot dismiss tongue tie out of hand, because anterior tongue tie is going to mess with the ability for the baby to elevate their tongue. It's going to mess with their ability to create a vacuum, and we need to fix that. Posterior tongue tie, we are not recommending that we even talk about that. That was when we were seeing the frenulum as a discrete structure that was aligned anteriorly to posteriorly. Now it is the fascia of the floor of the mouth, and it is not aligned in an anterior to posterior direction. And so we really need to understand that we are cutting into fascia, and that we need to have a good reason to do that. And we are not for posterior tongue tie. There is absolutely nothing to suggest that lip tie helps anything. I hope I've proved that point. Buccal ties, I can't help you with. There's no biological plausibility. There's no evidence. There's no studies. There's no nothing. And there is an incredible risk of complications from doing this procedure. So if I can just really emphasize that moms really need your help to breastfeed well. I think it's important that you have an ongoing dialogue with your lactation consultants, because I've been all over the world talking to lactation consultants, and they get very frustrated that pediatricians don't believe in tongue tie. And we really need to be part of this conversation. We are going to recommend that any baby that is going to be referred for frenotomy needs to return to the pediatrician before that happens, so that we can make sure that we are not missing out on other causes of poor feeding and poor weight gain in babies. But moms need our help breastfeeding. They're breastfeeding in higher numbers. And so I hope that I can get you to at least help those kids with the anterior tongue tie.
That was fantastic. Thank you so much. I think Dr. Lampert had a question. If you're on, you can verbally ask it. If not, I'll read it from the chat.
Yeah, I can ask it. So my question was, are we still recommending exclusive breastfeeding for 6 months now that some of the research about food allergies shows that early introduction of the like peanuts
the early
increases
introduction
the chance
is,
of allergy.
yeah, well, the early introduction is make sure the kids get it by a year of age. It doesn't say that the kids need it at 4 months. And the AAP's policy statement since 2012 is exclusive breastfeeding for 6 months, and that's not going to change. So the allergists have a very goal-oriented perspective. Our job is to see our kids in their complexity of risk factors. Breastfeeding itself is a way of preventing food allergy, and the early introduction of those proteins prior to a year is what we need to do. So I'm not sure why we have to start them at 4 months. 6 months is adequate to do that for their allergy. They fight with us, just so you know. I mean, this is a discussion we have at the AAP all the time, but it's not changing. It's going to be exclusive breastfeeding for 6 months because there's no benefit to starting at 4 months rather than 6.
Also too, Dr. Thomas, I don't think the audience saw the video. We heard the
Oh,
audio,
right.
but we didn't see the video. I don't know if you want to try to replay it now, or if there is a link that you can send to me, I can email to attendees afterwards.
Yeah, I can send you the link.
Okay, that'd be great. I'm not seeing any other questions. Certainly, if there are any participants that have them, please. Oh, Dr. Greenspan, please.
Hi. In our community, we're seeing a lot of referrals from lactation consultants to get craniosacral therapy and the feeding therapy. And I just want to make sure I understand that there's not evidence to support that.
Right. It's part of the tongue-tie community providers. There is the International Association of Tongue-tie Professionals. There's a tongue-tie groups, and what they're doing is they're going online saying this is a team approach. You need to go to physical therapy or occupational therapy or myofascial therapy, and we're going to get the baby ready to have their tongue released, and then afterwards, then you need to go back for craniosacral therapy. When you take a look at the studies that have been done for even just the poorly done randomized controlled trials, the improvement in pain is absolutely immediate. Like you see it right away, and you can see that from the ultrasound that if the baby now has adequate range of motion, now they're able to not beat up mom's nipple and not cause pain. And so it really speaks against any utility to those things unless the people that you're referring to know something about lactation. But what I've seen is just a lot of, and I feel like I'm, standing in two different worlds, but I've seen a lot of lactation consultants get very angry that pediatricians don't believe in this stuff. And I keep saying, you guys need to do evidence-based practice. Experience-based medicine is a ship that sailed in the 80s. You can't just say like, I've done this for years and it works. So I don't know what the benefit is to doing it, because if it's truly a tongue tie, it should get better as soon as we fix it.
Thank you.
And there's a question in the chat, and Carrie, I apologize, I don't know how to pronounce your last name. Do you want to ask it or should I read it? Well, she's asking, how would you recommend to become trained properly to clip an anterior tongue tie?
See one, do one, teach one, right? I actually hung out with an ear, nose, and throat doctor at my workplace, and he taught me, and I did it, and that's what I do. It's really, the purpose of the procedure is to destroy something. So it's really not that hard to do well, but I would to somebody in the community who doesn't use a laser, somebody who is going to use a scissor, and have them coach you through it a couple of times. That's what I did. It was very beneficial. And I love being able to do that in the setting of my outpatient clinic, because then I can assess the latch beforehand, see if the tongue is creating a problem, fix the problem, and go back and see, did this work? Because if you do a procedure that really doesn't help these moms, then we're back to square one. We really want these babies to get breast milk somehow. And if the tongue tie release didn't do it, then we got to figure out what else did.
Thank you very much. I appreciate it. I didn't know if you had to be certified to do that. Okay.
No. And a lot of the credentialing places in the hospitals don't actually see this as much of a surgery, because it's like 2 snips and it's easier to do than starting an IV. So at one of the institutions that I work, they wanted me to have some credentialing done, but every place else has been like, all right. So I use a circ tray.
Thank you very much. I appreciate it.
Mm-hmm.
And Dr. McAllister has a question next.
Yeah, I just have a question about the clipping the tongue tie. Do you get reimbursed for it by insurance?
Yeah, there's a code. There's a code, and I don't do it if the family has to pay out of pocket. But it creates a very nice equity, because anybody who comes in then, if you use the incision of the tongue fold tie, then you get reimbursed. So you get paid. Sorry, not reimbursed. You get paid. So it is a reimbursable procedure.
And Dr. Frazee is saying that is there an issue with malpractice? She doesn't think hers allows coverage for the procedure.
Yeah, and that I had to do that when I first started clipping anterior ties, and this was like 15 years ago. There's stories from people all over the US in terms of their malpractice insurance. It didn't affect mine, again, because the hospital system I work for right now doesn't see this as a major procedure. I don't have to have special surgical requirements to do this. The ENT that I worked with so it hasn't been an issue. It really has become one of those things that people worry about, because the malpractice insurance or the hospital credentialing can get in the way. But really, taking a sample from all of the different people who do breastfeeding medicine across the United States, it really just has not been a problem.
Great, I'm glad she asked. Anyone else want to chat or turn on your video and ask a question? Dr. Thomas is going to be back at 10:10 for her second talk today. So I'll lead the virtual round of applause. It was an excellent talk. Thank you so much. I think we are going to go to break, and I'll put back on our playlist, and I'll see everyone back here at 10:10. And we're going to have you for a drink and a party here in Las Vegas, Dr. Thomas, when you.
I'm going to hold you to that.
Absolutely. Thanks, everyone.